Probably would on a computer, but that's great.
Oh, and then you just change the angle in the front row.
Great, guys.
You just roll though. Yeah,
Which is like made of time.
If I need to like give a clue, no one will know.
Sure.
I think, yeah, I could probably
Where
have
does
my notes, like this one will be.
Hold on.
Yeah, yeah. I mean, I can't see those. I think that's better, because I know all that.
Oh, am I in this?
Oh my God.
Oh,
We are
yeah.
like directly in front of the camera.
Oh, good.
Oh, where is the recording equipment? Like, as it's like going online. It's like,
Oh my God.
oh my God. Okay.
Oh, that's great. I'm the only one you can see on that. So,
I think I need a mic for this room.
could be nice.
Yeah, I mean, on the website, I guess, like a week and a
Go see
half.
Karen.
Or on the odd Fridays. So we have something here every Friday. Yeah.
What do you mean every odd Friday?
Well, so every 2 weeks, it's THETA.
Okay.
And then on the alternate Friday, every 2 weeks, it's ClinEpi rounds. So every week, there's something here. It's just we alternate between ClinEpi and THETA rounds. And the ClinEpi rounds are the usual suspects around here. It's Bryanna Barr Nyhof and Shabir Alibi.
In charge of Massachusetts.
Yeah.
I do the both.
I know you do.
Why not?
Well, that's how it is for now. That's how it is for now. I mean, not because I want to do those things, but because there is. I'm also the division head from the Research Institute for that thing, so it makes more sense for me to do the ClinEpi ones. In terms of the THETA ones, to be honest, it depends on who has invited a speaker, and then that person generally runs the rounds. So it's
Good, fair enough.
anyway.
Hello.
Hi.
How are you?
You're Bryanna?
Yes, I am.
Okay, so welcome.
Thank you. And you are?
I'm Rick Ron.
Nice
I'm not
to
going to
meet
shake your
you. Oh,
hand.
okay.
And Charles, wash your hands because
Oh, okay.
I've got a cold. So
Oh,
I don't want you to be sick. Sorry, we shook hands,
Definitely.
But I shouldn't have shaken your hand either.
Oh, it's okay. I just had one. I think my immune system will cope.
Okay.
Thank you for warning me.
Okay, no problem. So you're working with Anna,
Yeah.
is that right? Okay, super. And you're doing something qualitative. And Charles is a surgeon, former head of many surgical things, and is very interested in.
Particularly breast.
Oh,
cancer,
wonderful.
all kinds, yeah.
Great. Look forward to your questions then.
Okay, so do I need to say anything specific to introduce you? Do you have a long CV that you would like me to read?
No.
No?
No, nothing. Just my name and
Okay.
master's.
Okay. And you have a posse?
Yeah. I don't know the deal.
We just voluntarily back here.
Okay.
Yeah. I did note it in my sort of what I said, Karen, but I'm defending my thesis at the end of July.
Oh, very good.
And so this is sort of,
This is a practice run.
yeah, in some ways it is, yes. It's a bit more detailed than what I'll present at that time. That presentation is about 20 minutes longer.
Super.
Yeah.
Do you ever make specific invitations to, relevance to the subject matter of people, or you just send out the general?
Oh, no, we invite people specifically.
Yeah. You don't happen to have any surgical pathologists coming today, do you? Or specifically invite?
No, not really. Well, when I say we specifically invite people, what I mean is I'm speaking about speakers, not. And people tend to sort of drift by. We get a different audience for every round, So we get clinical people that see the thing posted out there and say, "Oh, what's kind
Nothing
of
else to do at lunchtime. I think I'll pop in there."
Yeah.
Maybe they're serving coffee and sandwiches. These days are long fast.
Yeah.
Well, not for all rounds, but yeah, for us, we don't have our coffee and sandwiches budget, unfortunately.
In 2 o'clock Brazil is
Mhm.
Yeah.
Gotta tear myself away from the TV these days.
I think we have a group watch starting at 2 o'clock.
Yeah.
Somebody set up a TV somewhere.
Great.
Actually, this one.
This one? Okay. Set it up. So which one would
Right.
Yeah.
You know what happened this morning? France,
No.
2-0.
Oh, is that right?
Yeah.
And who are they playing again? I should.
Argentina.
Uruguay. There was almost a fight on the pitch. First I saw it got so close to a real physical fight.
I have the time. So anyway, this one.
It'll be, just give it till about 1:05. Yeah, so just give it a few more minutes. People drifting at the last minute.
What department is everyone from? So I know where my questions are going to come from.
Well, we have a formal thing. Everybody, we go around and ask everybody to explain who they are.
Oh, great. Okay.
Yeah. So just wait.
Oh, okay.
I'm sure they'll all come flooding in the next 5 minutes.
For sure.
No rush.
Yeah, no rush for me. The room cut off at 2, right?
Yeah.
I'm going to see if I can find it for you.
Oh, you're in the live stream.
I think there must be one. I think just that one. We only had a recording. So we logged on for Anna.
No, we have.
She's joining from 5
Oh, really?
So a washroom or anything?
Ask the leaders on the right.
Are you in that? Are you in?
That's a good one. So cute. I don't think that was not as good as mine.
Yeah.
I didn't do that. Oh, yeah. Action.
Okay, that sounds like that.
Well, my action is action is.
It's your first meeting?
Yeah. We're excited. We're excited to go.
Certainly. Well, a lot of people go wild. How long did you go before they?
First one, I was
My youngest sister, Maya, that kind of took a while.
and the kid doesn't know.
But it just feels a little strange when people ask.
Yeah.
Yeah,
It'll be.
yeah, be,
Good decisions take time.
yeah. If someone's late.
You're going to be listening to this for a while. Okay, maybe we should get started. So I am very happy to welcome Bryanna Barr Nyhof to present her upcoming MSc Defense. So this is a dry run, and she is a student working with Anna Gagliardi. And I think what we usually do is we go around the room. You have to introduce yourself, just say where you're from. So we'll start at the back. Can you start, Steve? Do you want to just start and then we'll go around like this?
So I'm Stephen Carconi. I'm a research associate at THETA.
I'm Madeline. I'm
going to be starting my master's in the fall with Dr. Angela Chung, so she recommended I sit in and listen.
I'm Anne-Marie Hospod. I'm also starting a master's with Dr. Jennifer Jones at Elixir.
Charles Wright. I'm an almost retired general surgeon, head of a university department, and chair of OTAC for many years.
Very Cron, Director of THETA.
I'm Claire Kim, and I'm currently a master's student with Anna.
I'm Di Ramanov. I'm a research associate with Anna Gagliardi as well. I'm Jessica Brennekin, and I am also starting a master's in September with Anna Gagliardi as well.
Yep, and I'm Bryanna Barr Nyhof. I will be presenting today. I'm hopefully finishing my master's very soon.
I'm Niva. I'm a research associate here and a PhD student at IHP.
I'm Brenda O'Connor. I'm a research nurse over at Sinai in the colorectal IBD group. So nice to see Dr. Wright again. We've talked on the phone.
Yeah.
Yeah. Work Dr. Collins.
I will be such a master's.
And last but not least, whose name?
Don't forget.
So I'm Snab Rahman. I'm with HPME, clinical epidemiologist at THETA.
Great. Okay, Bryanna.
So thank you all for being here on your Friday afternoon and joining me today to, like Mary said, sort of practice with seems like highly intelligent, critical, hopefully not too critical audience to practice my thesis defense. It's a little more detailed than what I'm going to defend, but without further ado, the title of my research is Exploring Patient-Centered Care for Women with Ductal Carcinoma in situ. I was privileged to have the experience to do my master's under Dr. Anna Gagliardi and a brilliant team of co-investigators across 5 different provinces in Canada. And we were generously funded by the Canadian Cancer Society Research Institute. So ductal carcinoma in situ, or DCIS, is defined as a spectrum of abnormal cells that are confined to the breast duct. And DCIS is not technically breast cancer, but it does present a risk for developing invasive breast cancer later on in life. But the challenge with DCIS is that there's no reliable way to determine which cases will progress and which will not. So that is why the standard of care for all women that are diagnosed with DCIS is that they receive surgical therapy, radiation therapy, and sometimes endocrine therapy, which is similar to women with invasive breast cancer. Worldwide, women with DCIS have consistently reported poor healthcare experiences. They have inaccurate understandings of their diagnosis, inaccurate risk perceptions of their risk for recurrence and progression, and have reported similar anxiety to women with invasive breast cancer, even though their prognosis is really quite good. Clinicians, some limited research that has been conducted with clinicians has also shown that clinicians find explaining DCIS really challenging to explain and discuss with their patients. Patient-centered care may be an approach to care for DCIS that would be beneficial and relevant given the communication issues that are persistent with DCIS. So patient-centered care in general is care that is empathetic, responsive to the needs and values of the individual patient, and has been shown to improve patient knowledge, relationship with providers, improve service experience, and its overall cost-effective service delivery. So in 2011, McCormick and colleagues rigorously developed a framework of 6 domains that sort of represents a gold standard best practices for patient-centered care and assessing patient-centered care. So this involves 6 domains from the beginning, the very initial part of the relationship. So from the farthest all the way to here, we have a patient-clinician relationship, and this involves discussion about roles and responsibilities, honesty, openness, and disclosure. So this is on both parts of the clinician and patient. Exchanging information is about knowledge, information needs, patient preferences for that information. Responding to emotions is identifying, exploring, assessing, and validating emotions, as well as providing tangible help for those emotions. Managing uncertainty, so all medical conditions have some degree of uncertainty, and DCIS is no exception. So constructing, defining, assessing, and understanding uncertainty is important here. Making decisions is communicating about decisional needs. What does the patient need to actually make a decision and feel informed about that decision? Preparing for and delivering about the choices, and finally making a choice. And then enabling patient self-management is the sort of the end off of the relationship, meaning that that patient is going into survivorship or in follow-up. And so learning and assessing what that patient needs, sharing and advising, and preparing and assisting with follow-up. In addition to patient-centered care, my research team suggested that we ask patients and clinicians about something called active surveillance. Active surveillance is sort of what you would say a hot topic right now for DCIS. And active surveillance is a type of expectant management that involves closely monitoring a patient's condition, but not giving any treatment, so no surgical treatment, unless there are changes in the test that signify that the condition is worsening. So in this case, it would be for mammography. So this is being considered because overtreatment for DCIS is a growing concern, especially for patients that are considered low risk. 3 clinical trials, 3 multi-center randomized control trials are happening right now, the Loris, Lord, and Common, and they're exploring whether there's a subset of women with DCIS that active surveillance can be used as an alternative to immediate therapy. And this may seem like sort of an outlandish thing to do when these patients may develop invasive breast cancer, but it in fact is already happening. It's already something that is being practiced for other pre-malignant conditions, and prostate cancer is probably the best known one of those. So the aim of our study, the main aim, was to generate insight on support needed by patients and clinicians to achieve patient-centered care for DCIS. We had 2 objectives: to identify patient-centered care experiences, needs, and preferences among women with DCIS, and to understand clinician challenges with patient-centered care and what they currently do that we consider patient-centered care. Additionally, as I said, we wanted to understand the perspectives of patients and clinicians about active surveillance. So we used proposed sampling to recruit general surgeons, surgical, medical, and radiation oncologists, and we used snowball sampling to further recruit radiologists, nurses, and patient navigators. We used a qualitative descriptive approach to our telephone interviews with the clinicians, and at the outset of the interview, we told clinicians that we were interested in patient-centered care. We then described what patient-centered care was and what it would look like. And then we continued to ask them questions about how they approach decision-making, how they approach conversations with patients, how they think that patient-centered care could improve care for DCIS patients, as well as active surveillance. We used a constant comparison approach to analyze the data. They're read independently, the transcripts are read independently by myself and my supervisor, Dr. Anna Gagliardi, for an extra set of rigor. And we discussed and developed a code book of themes together. Codes are organized by specialty, hospital setting, and self-reported years of practice. And the findings were analyzed by the McCormick framework. Patients, so like I said at the beginning, we had a large co-investigator group across 5 provinces, and we leveraged that network to proposively recruit patients from each of the provinces across Canada. So that's Ontario, Nova Scotia, Saskatchewan, Alberta, and BC. Focus groups were conducted by 3 members of the research team, myself, my supervisor, and another co-investigator, Dr. Robin Urquhart in Nova Scotia. And the interview guide was based off of the McCormick framework. The analysis was similar to that of clinicians, that we used constant comparison approach. Transcripts were read independently, and quotes were organized by theme, province, and patient-centered care domain. At the end of this, we then compared our findings from patients and clinicians using a constant comparison approach to identify similarities and differences between what patients said happened and what clinicians said they were doing. So basically what we did was that we organized the clinician and patient interviews by patient-centered care domain. We then compared the themes across the patient-centered care domain, and we decided if, based on that, if the domains were met or not met. So we had 46 clinicians in total that participated and were interviewed in the study. They varied by hospital setting, either academic or community. They varied by province. They varied by seniority or years of practice, and by specialty. And this is what we found. So our results are much more detailed, I would say, than what is here. But what is here really represents sort of the overall high-level findings that the detailed findings sort of emerged as. So within the fostering a patient-clinician relationship, we actually had very few clinicians. It was a total of 4 clinicians out of the 46 that mentioned anything about how they made the patient feel comfortable or how they facilitated a relationship with their patient. But the 4 that did mention this said that they focused on demonstrating patience in the encounter. They did this by their body language and through their explanations with patients. Within exchanging information, clinicians had variability in how they classified and described DCIS. So half of the clinicians, about half that we interviewed, thought of DCIS and labeled it as cancer. They said, yep, I describe it as early stage breast cancer, it's stage 0 breast cancer. Well, about the other half said, no, it's something different than cancer, and we describe it as abnormal cells or say DCIS. And so that's concerning. Talk about that later. Clinicians said that even after treatment and multiple consultations, patients remain uncertain. So this is even after they've had surgery, they still are uncertain about what they really have. We asked clinicians, how do you facilitate discussions with patients? What do you do to sort of help them understand? And almost every clinician said, I use self-drawn pictures. I personally draw them myself. And some clinicians said that this is beneficial because they were able to personalize the drawing, right with the patient. Others said, I actually don't have anything else to use. This is what I use, and I don't really think that it's the best way. Clinicians anticipated and responded to patient anxiety by something that we said was positively framing the diagnosis. So what I mean by this is that clinicians would often say to patients, you have the best case scenario of cancer. You have a lucky cancer. Let's say things like this. But then managing uncertainty of the diagnosis and prognosis of DCIS makes it especially challenging. This is recognized by clinicians. And so they said they often just never discuss with patients that not all DCIS progresses to invasive cancer. So clinicians often didn't know that, or patients often didn't know this. But in making decisions, many clinicians probed for patient preferences and engaged them in decision making, while many actually did not. They said that they either gave the two options, lumpectomy or mastectomy, but strongly advocated for one option over the other, or in some cases, some clinicians said, I don't actually give them both options when I know that they can have both options, because I'm worried that they're just going to go for mastectomy when they don't really need that. So they would actually choose for the patient instead of involving them in that decision. Within enabling patient self-management, almost all clinicians said that they gave them opportunities by phone and by follow-up, but they actually lacked supportive services that were appropriate for DCIS patients, meaning that they could only really recommend breast cancer general supportive services. So they would give them references for support groups that had sometimes breast cancer patients that were in stage 3 or 4, which is a very different experience when your life is being threatened versus someone who has a pre-malignant condition. And they lacked and were limited by the educational resources that they had available to them. So it would be impossible to show you every quote, but I chose these as the sort of examples of the findings that I just discussed. So this first clinician at the top, surgical oncologist, that I emphasize that it's not cancer, it's precancerous. I'm talking about precancer, so I'm not talking about cancer. I emphasize that a lot because I don't need any unnecessary anxiety from patients that they have cancer. I emphasize that it's 100% cured, that it's stage 0, which really means it's not cancer. Then the second quote, radiation oncologist. People talk about DCIS as being a precancer. Patients often come in from surgeons saying that, but I don't agree with that particular term. And if that's the case, I actually clarify and say it is breast cancer, but it's, very early. So this sort of shows you the inconsistency in wording between clinicians through the process of care. And the last one, I see patients at 6-month follow-up following surgery, usually after they've had all the radiotherapy, etc. They've met with all the other specialists. When I see them again, sometimes patients are still asking me whether or not they actually had cancer. Okay, moving on to patient participants. So we had health focus groups with 35 patients across 5 provinces who varied by age, treatment received, meaning that they either had lumpectomy or mastectomy with radiation therapy, time since diagnosis within 2 years, and family history of breast cancer. And these were, again, the higher level findings that we found within patients. So similar to clinicians, patients said that they valued patients when their clinician took time to actually build rapport with them, so get to know them as a person prior to diving into the clinical discussion. They said it's also important when their clinician expressed care through body language. And for an example of that would be instead of having a discussion across a desk, they would actually pull their chair around and sit beside them. Within exchanging information, patients also said that they had variable language, or variable language was used to describe DCIS, and in some cases, words were used that were synonymous with cancer. Patients had difficulty reconciling the diagnosis with the recommended treatment. So when a patient was described, or when a clinician described to a patient that they had pre-cancer, yet they needed a mastectomy, which often happens, this is very confusing, sort of a mismatch in patients' minds. Responding to patient emotions, patients said that they were emotional, but at times they didn't feel like they could be emotional with their physician. That wasn't the time or the place, and they wanted to save it for later. So that in some cases didn't give clinicians really a chance to respond to that emotion. So that's a challenge. They said it was helpful when clinicians provide tangible help. So in this case, they were talking about providing sort of follow-up contact information for them. They said that progression, the uncertainty of progression was not addressed because they were either told that they already had cancer or that getting cancer was inevitable. So many patients thought it was just a matter of time that they would have invasive breast cancer, and many were unprepared and uninformed about the potential outcomes of surgery. Within making decisions, they said that clinicians provided more than one option, but strongly recommended one option over the other, and patients often received the treatment that was recommended to them. And sometimes this was actually contrary to what they wanted. So a lot of patients said, well, I really wanted a mastectomy, but my doctor was really pushing lumpectomy and saying, no, we can wait for the mastectomy, and so that is what they had. They thought their doctor knew best. And some patients were just simply unaware of their role in decision-making. They weren't really sure that they could ask questions or disagree. And finally, enabling patient self-management. Many patients said that they had an abrupt separation after surgery with little information about how they were going to have follow-up or who was going to contact them. And their psychological needs were not well met following treatment. So again, these are examples of the quotes. So the first one is from a patient in Alberta. To be told it's a good cancer, it minimizes everything. It's still something really serious. So this is in response to a clinician positively framing the diagnosis. So they're saying that she has a good cancer, and this patient is saying it's actually a diminishing language. It's not really validating my experience. Second one by a patient in Nova Scotia says, you can't change what your treatment plan is. You can only go with what they offer you. This is a really good example of a patient and patients that may not know that they could be involved in their care and their decision making. And the final quote by a patient in BC is an example of how this particular patient didn't feel prepared for her outcome after surgery. She said, you're not feeling well because you can't lift your arms up, you can't do anything. I couldn't move anything. I was not prepared for that at all. There was no discussion of how impaired I'd be, 0. So then we did a comparison of patient and clinician findings, and this is really interesting to us because we found that patients and clinicians actually agreed on a lot of things that were happening. And so this is another level of sort of rigor or a cross-confirmation that we were interpreting what they were saying in an accurate way because it was also similarly represented in what clinicians were saying. However, they did also diverge or disagree or have inconsistent findings. So they agreed, both clinicians and patients agreed that when clinicians take time to build rapport with patients, this strengthens the relationship. They also said, they both agreed that variable terminology used to describe DCIS was confusing for patients. They said that DCIS-specific educational resources would improve patient understanding, so they both felt strongly about this. They both said that uncertainty of progression was generally not discussed, and patient decision-making preferences were generally not explored. Patients needed improved, accessible, and specific psychological resources during and following treatment. What they did disagree on, though, was that, like I sort of alluded to earlier, but clinicians felt it was helpful when they positively framed the DCIS diagnosis. They thought this actually allayed fears and calmed patients down. Patients actually said that was diminishing language to their experience, and they preferred not to have that. We asked clinicians, are you experienced in your conversations? Do you feel like you communicate well? Almost every clinician said that they really did. They felt confident in their communication. And this is contrary to the finding that patients said they often felt confused following discussions and desired more information from their clinicians. And finally, the finding that patients don't express their emotions outwardly, and that clinicians only offered emotional support when patients expressed outwardly, leads us to believe that it would be beneficial if patients were consistently offered emotional support, whether or not they expressed emotion. And the results of active surveillance. So we asked both. We asked the patients, what would you consider, or would you consider active surveillance as an option, as an alternative to immediate treatment? And then we asked clinicians, do you currently discuss the option of active surveillance? And if you don't, sort of what are your reasons, and what are your reasons for potentially discussing them? So interestingly, both patients and clinicians had similar reasoning, that they both had fear for undetected invasive disease. So with DCIS, there's biopsy undersampling, meaning that sometimes following surgery, a patient that has been diagnosed with DCIS can actually find out that it has progressed and that the biopsy just didn't detect that. And so they actually have invasive breast cancer. And patients, interestingly, said that they would consider active surveillance if DCIS was thought of as something, because DCIS is considered early stage cancer, that's another reason why they wouldn't consider it. But sort of contrary to that, a group of patients said that if DCIS was described as something other than cancer, so their clinician described it to them as abnormal cells or something different, then they may have actually considered active surveillance just by the wording that was used. And other patients said that if active surveillance was just offered at the time of diagnosis, that's what they would have chosen. Clinicians said that they actually needed guidance on how to safely provide active surveillance, and I think that's a good indication of sort of the importance of the studies that are happening right now, and that they will provide that guidance. Okay, so just some exemplar quotes. The first one was surgical oncologist. This quote is an example of actually active surveillance is already happening. People are already practicing active surveillance, but they're just not doing so. They're doing so with older individuals, women that have comorbidities, for example. So this clinician said somebody wasn't fit for surgery, especially if they're particularly elderly, where a pre-malignant condition is much less of a threat, and all of the other comorbidities, I would certainly consider that. The second person is talking about the guidance that they need and how they want to sort of go in this way. So they say, my gut says we need to be heading that way, but until there's sort of solid guidance on how to do it, I feel hesitant to do it. This final quote by a patient at BC said, if I had had the proper information provided to me at the very first day that all of this began, that's the option I would have chosen for sure. In hindsight, that's what I would have chosen because I don't think the surgery, I don't know if it was necessary. So just a very brief discussion. I know that that sort of a concentration or something that was coming up a lot was the label used for DCIS. And I've gotten a question before, like, is this really important? And does it matter what we call DCIS? And it really does, because the terminology to describe a medical condition has been shown to influence actually the surgical management practices and the psychological experiences of that patient. Secondly, patient decision-making was not always explored. In fact, in some cases, patients weren't given all the choices that when they really had those choices. And clinicians said that they did this based on sort of clinical reasoning, like it was sort of way too much, way over treatment if they did mastectomy. But it's important to know that women choose mastectomy for not only clinical reasons, but for personal reasons as well, such as wanting peace of mind. So if you're a woman that just doesn't want to keep going for tests, if you want to have a mastectomy and not think about it anymore, that is an option. There's inadequate informational and supportive resources for patients. So this isn't because clinicians are withholding this information or have all this great information and are not sharing them. We actually don't believe that there are really good resources out there for clinicians to share. And despite similar treatment experiences to invasive breast cancer patients, DCIS patients often sort of get the low end of the short stick in terms of resources that are out there. And I think that sort of overall, this research was not meant to sort of point a finger at any group that needs to really specifically improve, but actually this research demonstrates that clinicians face a lot of challenges, and they actually may need guidance and resources and feedback from patients about patient-centered care for DCIS. So our study had many strengths, we believe. It was the first to utilize qualitative methods to explore DCIS patient and clinician patient-centered care experiences. So before this research, there was actually no qualitative research whatsoever on what clinicians do, what they say to patients, why they say it, and their experiences and their recommendations. We felt we had a representative sample of clinicians and patients, given the diversity across Canada and the experiences that they came with. We had continual knowledge user feedback through our pan-Canadian research team, so we go to them continuously throughout the year and sort of knowledge check and member check our findings. And then findings from clinicians and patients were cross-confirmed to sort of improve that validity and support our recommendations. We also had limitations. The transferability of the findings to rural populations and community settings is a limitation, given that we were in main cities. Potentially important demographic information, such as socioeconomic status or education level, was not collected. And the demographic information that we did collect, we didn't actually link those to the responses of participants due to ethical reasons, and that may have given us sort of more insight as to what patients feel a certain way. Memory recall bias is a potential limitation when you collect information that is based on experience in the past, but we tried to mitigate this by having patients within 2 years that were treated within 2 years. And also, actually, family physicians was the final limitation on that list, because family physicians, we found through the study, are sometimes the first sort of person that patients find out about DCIS through. And so I think in terms of following the study and next steps, it would be an important population to look at. In conclusion, patients and clinicians face many challenges to patient-centered care. Above all, support for safe patient-clinician communication, engaging patients in decision-making, specific educational and psychological resources are most needed, and employing strategies that support patient-centered care can improve DCIS experiences for patients and clinicians. Thank you so much for listening.
Well, that was a terrific presentation on an extremely important aspect.
Thank you.
So I'm going to ask you a question, but just a few comments to get to the actual question. Are you familiar with the concept of root cause of issues? What's the root cause of the problem here?
Great question. I will try my best to answer this. I think that risk assessment with DCIS is a tough issue. DCIS is a heterogeneous disease, and clinicians, we don't yet have the ability to ascertain individual risk. So I think that may be part of this.
Okay, I would put it differently.
Okay.
And you're much too sweet and kind to clinicians and pathologists and surgeons who have made such an incredible mess. Now, you may not be aware of, you are aware of the international movement of overtreatment and overdiagnosis. Mm-hmm. And the 3 cancer issues in surgery that are top of the list, and there's many others, are DCIS, papillary cancer of the thyroid, and prostate cancer. And in each of these cases, why is the word cancer still in the pathology report? That is the root cause, in my ever humble opinion. Because the pathologists, and I can tell you, I started addressing this issue years ago when I was chair of OTAC, and actually I have continued. My last interview with the senior pathologist was 6 weeks ago. They will not look at the issue, which is bizarre, they need to drop the word cancer now. The National Cancer Institute 5 years ago set up a task force that published on this issue. I don't know if you're familiar with that. I can give you all the references. So I'm wondering how much you're going to address this in your thesis, because it's a wonderful opportunity to be a little more edgy, perhaps, in recognizing the root cause here of continuing to use the word cancer in what is, in fact, an intraepithelial lesion. That is the absolute key. And what's even more interesting is that gynecology pathologists have seen the light a long time ago. You know what they used to call cancer of the cervix, stage 0? I mean, that's an intellectually destitute position, to call something stage 0 cancer. And as soon as the word cancer is on the report, and the GP or the clinician is sitting with the patient saying, "Oh, I'm sorry to tell you, you've got cancer," it immediately prevents or makes it extremely difficult to do what you're very properly trying to do here, namely to find a way through the communication issue with the patient. So it is, and the NCI, the National Cancer Institute, has published this. They made a kind of, in my opinion, sort of silly suggestion. They said they should be called idle lesions, idle standing for indolent lesions of epithelial origin. But here we are with the gynecology world accepting that what used to be called cancer is not called it anymore. It's called, do you know what it's called in the gynecology world? It's called CIN, intraepithelial, cervical intraepithelial neoplasia. And there's a big movement on at the moment to even change that to something even more benign, namely it's squamous intraepithelial lesion. That's all, just a lesion, because what it becomes is either a complete cure or can become a cancer. So I'd love to see your thesis dealing with this as a core issue that will have to change to help women through this mess that we've created with nomenclature. In fact, if you turn to slide 18, can you do that?
Yeah.
Quickly? I don't want to monopolize the whole discussion here. Well, I'd love to make a formal presentation on that, actually.
You would have to give rounds. You can't jump around. You don't want to give your formal presentation.
You're dead right. What is number one in your list? The labeling. Labeling matters, because that cancer word violates all possibility of a sensible discussion with many people as soon as that word's in the list. And okay, I'll give you my last comment. In my process of getting involved in this and with pathologists, I have consulted every known English dictionary, including all the medical dictionaries and all the just English language dictionaries. Do you know what the word cancer says? It needs two things. One, out of control growth. Two, outside of its usual boundary. Will the pathologists still attach the word cancer to papillary thyroid or DCIS or most of the prostate? So I don't know how you can do a thesis which is so important as yours is without maybe making more of that issue.
Excellent point. We do discuss that in the full thesis. I can send you a copy. But we did actually have that feedback from both patients and clinicians, and perhaps I should emphasize that more, that both patients and clinicians said the word cancer scares patients. Patients say as soon as you said ductal carcinoma, they sort of stop listening and they have difficulty regulating their emotions after that and listening to anything after that. So I think it's important. Like you said, there's been numerous committees and experts far more experienced than I am here to discuss that issue, and they still haven't resolved something. I think, yeah, Murray, do you want to?
Well, I mean, so I hear this. I mean, I think that the labeling issue is something that extends beyond cancer, and clinically, I agree that patients, of the labels that one could use, that is perhaps the most powerful one.
Mm-hmm.
Having said that, like the whole issue of labeling in medicine is not, you know, the evidence is not consistent that this carries a lot. I mean, this goes back to the 1980s, for example, when people in Hamilton labeled patients as being hypertensive and they found increased absenteeism. So, you know, there's evidence for that. But when people have tried to study the issue of labeling in other contexts, they often haven't been able to demonstrate a measurable impact on quality of life, for example, as opposed to, you know, associated with the label itself. So, you know, I mean, from my perspective, it sounds like the labeling is important, maybe not as important as high quality evidence, knowing how to manage patients. So, for example, in the prostate world, whether it's called cancer or not, low Gleason grade cancer, there's like large trials telling us what happens when they're managed with active surveillance versus sort of active treatment. So we have a pretty good idea of what proportion of people will progress under each of those circumstances, what proportion of people will die of cancer. So how much of the problem in managing this is actually related to evidentiary uncertainty about how best to manage this condition, irrespective of how it's labeled?
Yeah.
Well, that's a question.
Yeah, the question. Oh, okay. I think that was similar to my answer to the root cause, is that physicians need more evidence and they need better risk assessment tools to be able to.
So it's not just risk, though. You need comparative. I mean, to just say something bad will happen or not, like you need to know the counterfactual too, right? You need to know if you have a lumpectomy or mastectomy, this is what will happen to you. If you are managed with active surveillance, this is what will happen to you. And the difference between these two options is the following.
Mm-hmm.
That's the kind of thing that you see from randomized trials. So are there any randomized trials in this area comparing active surveillance to?
Not yet, not with active surveillance, but there are randomized control trials that informed the guidelines, the clinical guidelines that CCO produced. They compared lumpectomy with radiation therapy and mastectomy. So there's that evidence that shows that there's no significant difference between those two clinical surgical options. But because the active surveillance work is so early, and even just proving that it's even a good option for patients with low-grade DCIS, we don't have that evidence, but I think that's a perfect next step for them. And I just want to touch back on your question about changing the label, because patients actually, even if you change the label, you don't change the treatment that they receive. And so patients already have difficulty with pre-cancer and then being told they have a mastectomy. And then maybe if they're told that they have neoplasia, something that's even sort of more benign sounding, they still have to go through these really invasive, extensive surgeries. And so.
And that's because of the history of the management of cancer. You see, the other anomaly here, which is very unfortunate, but it's factual, invasive breast cancer is rarely multifocal. Mm-hmm. DCIS is commonly multifocal. So we have this incredible stupidity of clinical management where DCIS, which is not a cancer unless it may become one in an unknown percentage of people, but actually that percentage is now getting narrowed down because of the revision of breast screening, long-term trials, and so on. We're looking at the incidence of invasive cancer, which is never in doubt pathologically. So the anomaly is that it's not unusual for a DCIS patient to end up with more extensive and nasty treatment than somebody with a defined lump, because lumpectomy and then radiotherapy is standard with a without chemo, and all that debate still goes on. But for DCIS, multifocal. So mastectomy is, if anything, more common, which is incredible. It just doesn't recognize the issue because of the label.
So I'm assuming there's no data on how these patients progress with DCIS. Say they had active surveillance. There's no like transition probability data of how many of them would end up with the T1 or greater having active surveillance, or
So these are in-process trials right now, so we don't actually know the long-term data of them. We do have some sort of indirect evidence based on post-mortem research where there's where they do an autopsy and they find DCIS in someone who had sort of low-grade DCIS and it never affected their life. So we have sort of indirect evidence, but no sort of hard randomized control trial evidence yet.
Well, the analysis of screening programs and the Danish group of the Cochrane Foundation has been on this for years, and everybody just ignores it, continues to ignore it. They have a statistical range of good estimates based on fact as to screening, because a substantial proportion of screening detected, quote, cancers, unquote, are DCIS, which should not be included in the cancer statistics. But they are, of course, because programs like to make it look as big a problem as possible from their vested interest.
Any other questions? I'm just going to ask one last question. Maybe I asked this already. Like, do you think there's anything to be learned from the prostate world, because they've been down this exact same road, and this issue of overdiagnosis and overtreatment is there as well. This issue of living with uncertainty in the prostate world is called PSA dynia. People live and die with their PSA level. That's after treatment, but also before. Men who are in these active surveillance programs, they also have to live with the fact that they still have a cancer in them, which, for reasons as you quite lucidly explained, like a lot of people don't want to walk around with cancer in them if it could be out, or because they want to be reminded that just the idea of having something foreign in their body and having it out is very attractive to people. And also this whole issue of active surveillance. We in Ontario here were the ones that published the first big trials on active surveillance of prostate cancer. So I just wonder if there are kind of lessons to be learned from the prostate world for the DCIS world. I don't know. I mean, in your reading, did you come across those same kinds of parallels, or does that seem like these are different worlds and different problems?
In some ways, yes. In some ways, no. Different issues. They often, in all the trials, they reference a lot of prostate work. I think when I look at the qualitative work, which is what I think to focus on or have a inkling towards, is that I think breast cancer is a little different than prostate cancer, and the experiences that happen when you lose your breast versus your prostate, and the side effects that men are avoiding by having active surveillance.
Maybe. Yeah, that's a good point, I think. It is. I mean, I think there are instructive parallels. You tend to think of it as being quite different because it's women versus men, and a breast versus something in the pelvis. And so, like, your initial response to this is that these are quite separate things. And yet, for men, they're dealing with issues of sexuality, which are sort of lifestyle issues. They're different issues that women deal with, which are more body image issues, but they're also tied up in sexuality and people's self-image of themselves, but in some ways maybe less different than you think. anyway, it's really not so much a question as a comment. I think there are a lot of parallels from what you've described.
Yeah, that's a good point.
Seeing as you raised the issue, Marie, and it's only 10 to 2.
Everybody thought they were going to get out of here.
No, I mean, I think it's so serious. It's again, to get hung up on the nomenclature. How can you call a cancer a quote disease that is present in almost 100% of men who are otherwise healthy and hit by a truck if you do an autopsy at the age of 80 and older? I mean, it's huge. It's massive. In other words, I would like to call them funny-looking cells.
You could.
The pathologists call them cancer.
Cells kill 2,000 men a year in Canada. You know, like those. There are a lot of people who die from those things, and I look after a lot of them on the board here, and it's a very unpleasant death. So you have a.
Well, you're talking about invasive prostate cancer.
Yeah, but you know,
that's
story. Anyway, we're talking prostate, not talking BCIS.
So what do you think about thyroid, seeing as you raised the issue?
I absolutely know nothing about thyroid. I do think, though, that nomenclature is important, but it's not the whole story. The issue is whatever this is, we need to know how to deal with it. And both of these things are highly, the patient has to play a big role in this because there's a risk-benefit calculation to be made. And because the consequences of this are quite variably experienced by patients. You know, they're, both a breast and a prostate are tied up in sexuality and self-image and stuff like that. So those are things that vary quite widely. In men, for example, like sexuality in some people, is not a big deal. They don't have a partner or they haven't been sexually active for a long time anyway. And so avoiding sexual dysfunction after treatment, which is what people spend a lot of time thinking about, it's just not an issue. Whereas for other people, they have a new partner and they have, they're very sexually active, and that's like a big deal for them. And I'm sure for women it's the same. For some women, having preserving their breast is quite a big deal. And for others, it's just not. And I don't know. I think these are the role of patients in decision making is important. Will be important for both, but doing the risk-benefit calculation and getting the highest quality evidence is, in my view, probably closer to the root cause of the problem, irrespective of whether you call it cancer or not. If you know that from randomized trial evidence that people live longer with treatment A versus treatment B, it doesn't matter what you call it. You just know you should have treatment A for this thing that ails you. It is true that labeling causes tremendous anxiety and probably tremendous overtreatment. I totally get that. I believe that. But I think the problem is still that we don't have the trials to tell us what to do. That would be my uninformed judgment.
And actually, the probably most challenging thing with DCIS and what patients will tell you is that the evidence shows that there is no difference between the options. And so this is a preference-sensitive condition.
But you just said that we don't have the trials.
Between the surgical treatment that's available.
Oh, yeah. But I mean, the key thing is, so that's a very small issue. Well, in fact, it's not a small issue. It is. I don't know why I'm talking all the time. Like I feel
there's a big difference in the incidence and complications from what mode of treatment.
Right. No, so fair enough, but it's less of a difference than active surveillance versus either of the other two. And by focusing on the non-invasiveness of this, it seems to me like the biggest anxiety around this issue is whether you should be doing anything surgical at all, rather than whether you should be doing lumpectomy versus.
But it is very relevant, and for example, mentioning thyroid, it is surprising in a way, but the world of thyroid surgery is getting the message in terms of realizing that this is not a disease that grows, particularly in younger females with papillary cancer, whereas the incidence has gone up, would you believe, 600% in the last 2 decades, the incidence of the disease. So what's that telling you?
Is similar.
And what's happened to the mortality of thyroid cancer? it stayed at an almost unmeasurable level.
You're tapping into a reservoir of indolent.
No, it's
something that would never
MRI.
It's the imaging
all
that's
the
gotten better.
That show how many normal people have lumps in the thyroid, and the incidence is about 30%.
Yeah, that's what DCIS, when we introduced population-based mammographic screening, it went up 534%. You know, and that seems like a shocking number, but really these people are not dying from DCIS.
Okay, here's a question for you. What is the incidence of DCIS in a population of women by age?
By age?
In other words, if you do, these are tough studies to do. Autopsies on women who have died of other diseases, who have given permission for a serial section of the breast.
Yeah.
There are several trials. It's very high. It's the same problem. In other words, it's a normal variant.
Yeah.
So I think we're going to let you go. Wish you good luck for your presentation, and thank you again for your.
Thank you for your questions, and I don't know if I have my email up there, and I don't. But it's my name, and then UHN research.ca.
Okay.
Thank you. Good luck with the game.
Thank you.
Thank you so much.
That was very good.
Thank you. Thank you for your questions. Lots to think about.
So there's something about slide 4 that I wanted to ask you.
Oh, okay. Yes.
Are you in a rush to?
No, I'm fine. Sure.
Yeah. You mean like to do modeling?
Yeah, the over-treatment. The over-diagnosis. Inevitably, the over-treatment.
Yeah.
I'm sure that's known.
But if you know that, then you know that accuracy.
No. You don't know that.
You said it was
know
times
the
the
proportion of
physicians?
patients that advanced to T1 and greater.
Yeah, you said it was 2
that had
times
access
the
to
physicians?
If all of them had a physician.
2 times, 2 next to them.
You
Yeah, you said. Because we have physicians on my team who said, you're being too harsh. With us.
Absolutely not.
So I framed it differently now.
Delayed surgery conditional on that risk.
No, I like
You still have to say, okay, let's see. Let's get the people with randomize them to medium mastectomy. And the other ones were randomized to active surveillance with all the no, those are the trials. Prostate.
This structure can sell. Doesn't look normal, and that's
but for maternity review, you will just see.
So it takes no account of whatever
observed
behavior.
Yeah.
So what?
Yes.
So you can never. So why do you need some randomized trial?
Yep.
I mean, if we can. That's right. So you can, like, with the kind of studies that we do, we can do our best to, like, we can compare outcomes for people who have had and not. But in the cancer world, like, you try to draw inferences based on observational data, especially right
So important.
like in cancer screening in particular.
I used to dread,
look at
breast surgery was my major
they don't.
issue.
But I find it hard, like, if you have, in a 5-year span, if 100% of the
day,
DCIS
have an appointment to see a
why
surgeon.
we would offer kind of X-rays.
Well, they don't. I mean, obviously.
I'm not 100, but I'm high.
So the
I
numbers
just
low.
knew, so
the
look at
numbers are quite
what's going
low.
to be happening here, because they were referred to as surgery.
Oh, I don't think so. It'll probably be.
I suspect that's why she's physician calling it cancer.
And suspicion
No,
more
they're
than not was
No, they're calling it cancer because when they look at it,
it turns out to be DCIS.
so
But even to get that,
this is a histological
you have to do invasive.
I know.
thing. All right, on to Belgium versus whoever. Who's Belgium saying again?
An actual
Who?
tissue biopsy.
Are they making it all right?
Yeah, you often have to go through these stages. You end up diagnosing cancer, which is DC type.
Yeah. Yeah. Oh, okay.
yeah, I gotta get to a TV.
Yeah.
Can you get all the channels here from Rogers? Or? So
Yeah.
you want,
American
sign into
down here.
my TV subscription,
yeah.
and I could stream them.
Uh-huh.
I just don't know if it would work on this network. I know it works on my terminal in my office.
Which team are you supporting? That's the
Oh, they're long gone.
Oh.
Italy.